Good afternoon, everybody. My name is Joanna Teters, and I'm the Community Outreach and Resource Manager at CurePSP. And welcome to Ask the Doctor. This is our fourth webinar, a conversation with Dr. Golbe. This will be a recorded webinar, and the recording will be made available on our website in the next few days, and a link will be provided in a follow-up email as well. Thank you so much for joining us today. Please note that we are using Zoom, and Zoom is not a confidential platform and it is not HIPAA compliant. Any disclosure of personal information may be revealed to others in the group, including those not logged into the program. We expect everyone to respect confidentiality of who attends and what is shared. By choosing to attend the meeting, this webinar, you are consenting to participation. A quick Zoom overview. Please type your questions in the Q&A function of the webinar. If you have the same question that's already in the Q&A function, please like it to avoid duplicates. There will be a thumbs up button that you can click. You can also use the chat box to interact with each other, and please do not reveal any personal medical information. If you write in a question in the chat box, it may not be answered in this webinar today, but we will consider it for our next webinar. Our next webinar is going to be on August 11th at 2 p.m. Eastern Time. That's a Tuesday, and it will be featuring Dr. Alexander Panteliat. We're very excited to have Dr. Panteliat join us for this webinar series. So please join us and mark your calendars for August 11th at 2 p.m. Eastern Time. But at this time, I'd like to welcome Dr. Lawrence Golbe, one of the world's leading clinical experts in progressive supranuclear palsy and related neurodegenerative conditions. Today we'll be mainly talking about PSP, CBD, and MSA. Dr. Golbe has been long associated with CurePSP as a board member, director of clinical affairs, and head of its scientific advisory board. He also serves as emeritus professor of neurology at Rutgers Robert Wood Johnson Medical School, where he teaches, performs research, and has a referral practice confined to PSP and CBD. He is the author of A Clinician's Guide to Progressive Supranuclear Palsy, which emphasizes early diagnostic signs, medication options, non-pharmacologic management, and palliative care. Today, Dr. Golbe will be answering questions that were previously submitted by patients and families between the time of our last webinar and this afternoon. If we have time at the end of the meeting, we may open up the proverbial floor for some questions. Please note that any medications that are referred to in this video should not be tried unless under the supervision of a medical professional. This webinar is also going to be streaming live on Facebook. And as I said, this video is being recorded, and the recording will be made available on our website and our CurePSP TV YouTube channel in the next few days. At this time, we're going to ask Larry to share his screen, and we're going to jump right into some Q&A. Thanks for being here with us, Larry.
Well, thank you for doing this, Joanna. I always appreciate your introduction. Full disclosure, you talked about what I'm doing in my job at Rutgers, seeing patients and stuff. Just for the record, I retired from that a week ago. So I don't see patients anymore, but I still do clinical trials, and I still work as much as ever with CurePSP, and I hope even to increase my involvement with CurePSP going forward. Okay, so
and congratulations on your retirement.
Thank you. We are going to, I have a list of 16 questions that were submitted in advance. I'll take them in kind of random order. For the first time, there are no questions relating to COVID, so I will not discuss that. Here's a question that may sound kind of, I don't know, irrelevant, but really it's not. Is sugar related to tau protein? Well, sugar in the sense of glucose or sucrose, the type of thing that's a problem with diabetics, that is not, as far as we know, related to the tau protein in any important way. In case you're new to this business, what is the tau protein? That's a normal protein that's in the brain cells, which if you have PSP or a couple of dozen other diseases, the tau protein forms these tangles. Normally the tau protein is just floating around in the fluid in the brain cells, or it's attached in a specific spot where it does a certain job. But if you have PSP, it detaches from that spot and it forms these tangles. Like if you let the spaghetti boil away, if you let the water boil away, the spaghetti forms a big tangle. So sugar has nothing to do with that. But there is a different type of sugar, not glucose, which can attach to the tau protein as a normal part of the tau protein's function. It's called N-acetylglucosamine. And the purpose of the N-acetylglucosamine attached to the tau is to prevent it from forming these abnormal tangles. I mean, it doesn't completely prevent it, but it tends to prevent it, to reduce the chance of that happening. And there's an enzyme that attaches the sugar. There's another enzyme that detaches the sugar. And there's a couple of different drugs that can inhibit the enzyme that detaches the sugar. And those drugs are starting to enter clinical trials for PSP now, probably within lockdown. Of course, we don't know what's going to happen with the lockdown, but aside from that, at least one of those trials was set to start within the next few months. The enzyme is called OGA, and the drugs as a class are called OGA inhibitors. So the answer is yes, a special unusual type of sugar is related to PSP, but it's not a sugar that's in our food. So there's no point in modifying one's diet to try to prevent PSP. That would be nice if that were true. Here's a question. What makes the centers of care special? And what capabilities do they have? Okay, well, the CurePSP centers of care. These are, you may be familiar with other organizations have centers of excellence. This is the same thing. These are medical school departments of neurology where there is some expertise and interest in taking care of people with PSP. It's not necessarily research activity, it's clinical care. And CurePSP a couple of years ago put out an announcement asking for centers to apply. And we have a set of criteria. It's about 25 items that we made into an application, and the director of the site filled out the application with saying things like how many patients with PSP they'll see in a year, what doctors are working there, what their training is, how much experience the doctors have, how much publishing in PSP. Even though this is not a research exercise, still having published something in PSP is a clue, a piece of evidence that there's some expertise. Also, the geographical location is important because we'd like to spread out these centers. We can't have a center in every city, but we'd like to make it possible for somebody somewhere in the United States or Canada to not have to drive more than about 2 or 3 hours to get to one of the centers. So right now there are 22 centers. They're spread all over the country, although oddly the Northeast is underrepresented. There's one in Boston, and there's me in New Jersey, and then that's it for New Jersey and New England and New York. There's none in New York yet. Anyway, so the centers of care have those capabilities. There's a list of them on the CurePSP website, and these are doctors who, unlike many neurologists, when confronted with a person with PSP, they will not say, sorry, I can't do anything for you, go back to your primary care doctor. They will not say that. And if they do, I want to know about it because I'm the director of the whole project. Okay. Oh, and by the way, the centers are presently collaborating on a big project to write up a paper to be published on best clinical practices for managing PSP and CBD. And we're almost done, and that might be published sometime before the end of this calendar year, most likely. Okay, next question. Do you think stem cells will help with treating PSP? When my kids were born, we had saved the stem cells with a bank. There are businesses in the business of saving stem cells. Even before there's very much application for it, still there are banks, there are tissue banks that will charge you a nice piece of change to store the cells every year. So far, this is not useful in treating PSP, not saying that it may not in the future, but so far it's not. And it seems quite likely that the stem cells, the type of stem cells that might be most useful for treating PSP or anything else are stem cells from the patient himself or herself. And these stem cells would be taken from a skin biopsy, most likely, where there's a little punch taken out of the skin that's maybe 1/8 of an inch in diameter under local anesthetic, under Novocaine, and it's put a Band-Aid over it, and the lowest layer of the skin, which is not really turned into skin cells yet, it's still a very generic type of cell, those cells can get turned into stem cells, and then the stem cells can be converted into brain cells in a dish, and then they can be put into the brain in various ways. There's just dozens of different ways that stem cells might be useful in treating different neurological diseases. So it's a good question whether you should continue to bank the stem cells that you've already got banked. I suppose you've already invested, which is a point in favor of continuing to do so. But if somebody would ask me, well, I have PSP and my grandchild is about to be born, should we harvest stem cells from the blood from the umbilical cord from the placenta? I would say probably don't bother. You may find differing opinions on that. Okay, any suggestions on computer apps, mobile apps, or devices to help with communication with a patient with PSP who can't talk or move and can only blink? First of all, I don't want you to be frightened by this. This is not, this very advanced stage of PSP is not something that most people with PSP really attain, although some people do. They can be just very immobile and can't speak at the very last stages. This, of course, is a dangerous situation, and usually this occurs, I mean, usually death would occur not too long after that. You've heard of people being locked in from a big stroke of the brainstem. That's different because that's something that doesn't get worse over time. Also, that doesn't affect the mind. PSP, of course, affects the mind. It causes dementia in the majority of cases eventually. So the question about whether there might be devices that can perceive eye blinks, yes, there are such devices that can, where the person can blink 1, 2, or 3 times to indicate, I don't know, yes, no, right, left, and this can be transduced into the movement of a cursor on a computer screen so that you can then very laboriously type out messages. If you've ever used a streaming service and you wanted to type in the name of a movie or something, it's that kind of, using your remote, it's that kind of a very time-consuming process. Now, I've never actually seen this work with PSP. If you do want to explore this, I would suggest contacting a neuro rehab institute. We have a couple of really good ones here in New Jersey. but they're all over the place. Neuro rehab. The problem with teaching somebody with PSP to do this is that somebody with advanced PSP has a hard time concentrating on a task, has a hard time learning new things, has a hard time planning, and it might be very difficult to teach them to do this task. But it's worth talking to a neuro rehab specialist to see, because the technology is improving all the time. So I would encourage you to at least explore that. And the neuro rehab specialist has many other things to offer to somebody with PSP. In fact, what I do for my patients with PSP really amounts to neuro rehab, because I don't have a cure yet. And so everything I do really can be categorized as rehab. Okay, here's an interesting question. This sort of starts to border into the territory of an individual medical question, but I think I can turn it into a generalized question. If somebody's been diagnosed with, quote, Parkinsonism, as opposed to Parkinson's disease, and has some of the eye symptoms of PSP, such as trouble looking up or down, lid twitching to the point of double vision, which is not usually happen in PSP. Lid twitching can happen in anybody, healthy people. Would these visual symptoms be enough for a PSP diagnosis? All right, well, first of all, what do I mean by Parkinsonism? Parkinsonism is just a collection of signs and symptoms. It's not one specific disease. It's a syndrome. It's not a collection of signs and symptoms. And the signs and symptoms are general slowness and stiffness and poor balance and sometimes tremor. That's Parkinsonism. And many different things can cause it, some of which are progressive, degenerative, like PSP and Parkinson's disease, and MSA and corticobasal degeneration. Other things can be static, can be non-progressive. For example, certain sedative tranquilizer medications can cause this. And then when the medications are stopped, the symptoms can go away. There are certain types of injuries or tumors or different things can go wrong with the brain that can mimic that same set of signs and symptoms. And that's why anybody with this needs an MRI or at least a CAT scan to look for those things. Okay, so what's the most common cause of Parkinsonism? That's Parkinson's disease by far, although the drug-induced is, I think, a close second. But of degenerative Parkinsonism, the most common is Parkinson's disease. And the things that are degenerative but don't look like Parkinson's, including PSP and MSA and CBD, those are called atypical Parkinsonisms. I don't like the word atypical. It's just that they're unusual. So if you have the Parkinsonism syndrome, the slowness, the stiffness, the balance, maybe the tremor, and you have these eye movements on top of it, is that enough for PSP? Well, not quite. There needs to be other things. I'm not going to get into the details of the diagnostic criteria for PSP, but, and it depends what kind of eye movements they are. So based on the information in the question, the answer is no, especially because any of the Parkinsonisms, including Parkinson's disease, can cause some degree of eye movement problem. Okay. What can be done for stiff neck? Well, in the context of PSP, stiff neck means difficulty moving the head in this direction, the yes-no direction, the yes direction. What can be done for that? It's worth trying carbidopa-levodopa, that's Sinemet. That's the standard drug used for Parkinson's disease, to which it responds very well. In PSP, only a minority of people will respond. They usually don't respond as well as they do with Parkinson's, but it's still worth trying for anybody with stiffness in the neck. I don't want to suggest that this stiffness is painful. A stiff neck, you wake up from sleep because you slept in the wrong position. and you have a stiff neck, that's different. That's a purely muscle issue. This is a muscle or tendon issue. This is a brain issue in PSP, and it's not usually painful. Sometimes in the more advanced stages of PSP, it can be a little painful because if you're in this position all the time, the muscles in the back of the neck are constantly contracting, and so obviously that would become sore. It's like laying on the same side of your body the whole night through. You don't get adequate circulation to the muscle, so it starts to use other methods of producing its energy, like fermentation rather than respiration with oxygen. The fermentation gives off lactic acid, and lactic acid is irritating. All right, so that's a gruesomely detailed account of what causes discomfort if you are contracting one muscle for too long. And what can be done for that? Sometimes Botox injections can help, although it can be tricky shooting Botox into the neck muscles because the Botox can leak around the front to the swallowing muscles, and usually those are already having a problem with PSP, not the muscles themselves, but the brain's control of the muscles. And if you weaken the swallowing muscles, it can cause aspiration. But used very judiciously, very small amount for the first dose, and a trial and error basis. A good neurologist who knows how to do that, or a neuro rehab specialist, or sometimes orthopedic surgeons do this. That might help a stiff neck. Local heat can help as well. And I've seen I've seen one or two articles in the literature about using intravenous lidocaine. This is a lidocaine, of course, is a local anesthetic, but it can be used intravenously. You have to be an anesthesiologist to do this. It can be used intravenously for people with very bad diffuse pain, and it has worked in people who have bad pain from stiff neck of PSP. But that's something that would be done at a special pain medicine center. Okay, next question. State of clinical trials, and which ones are looking the most promising? All right, well, the pandemic lockdown has brought the clinical trials in PSP to a screeching halt. Actually, there weren't any going on at the start of the pandemic, but there was at least one that was going to start up pretty soon, and that is now been postponed until next spring, till April. And that's the next one on tap, as far as I know. Now, the drug companies don't keep me informed of their plans. I have to hear about these things through the grapevine, or if they ask me to be a test site, then I'll hear about it. But that's the next one I know of that is going to start. That's the drug company is UCB, based in Belgium. And that is an intravenous monoclonal antibody to slow the course of PSP. There's a bunch of other types of drugs that are being planned. One is that OGA inhibitor I mentioned before. That's an oral drug. Another one is a drug that has to be injected into the spinal fluid, which in the lower back, like with a spinal tap. That's a very innovative type drug that would prevent the production of the tau protein to begin with. So those are the most promising ones right now. Okay, next question. What was the name of the medication you prescribed for Apraxia? I have mentioned this in a previous Q&A. The name of the medication is amantadine. The success I've had with it for Apraxia is really in the gait apraxia. There's a type of walking problem where you just can't take that first step. But once you take the first step, then you're okay for a few steps at least, and then you're okay until you either try to make a turn or until you stop and then try to start again, or until you reach some kind of a threshold, like trying to cross into another room or go from the carpet to the bare floor. Some kind of a visual threshold can freeze you up again, and then you can't get started. So that's apraxia. And oddly, using another type of locomotion, like walking sideways or backwards or running, can overcome the apraxia. And there's all sorts of tricks for how to overcome the freeze. But amantadine is a drug that can sometimes work. Amantadine can certainly have a share of side effects, but used carefully and not going beyond only a moderate dosage is certainly worth trying for somebody with apraxia of gait. And people who have other types of apraxia, I'll give amantadine a try, and it'll only take about a month to see if it's going to work. And if it doesn't, then I forget about it. The other types of apraxia might be for manual tasks. For example, if I tell the person, show me the V for victory sign, instead of doing this, they will kind of they'll look at their hand and figure out what's going on, and then they'll take their other hand and do that. So it's as if they needed practice doing it, like a child trying to do it for the first time. That's apraxia. And it can be caused by many different types of diseases, not just PSP. People with strokes can get it, people with Alzheimer's. Okay, next question. Coughing and choking. Why does it happen, and what can be done to prevent it? That's a big issue with PSP, very important. I know I've covered it before, but it's worth covering again. The coughing and choking is mainly because there's trouble swallowing. And the trouble swallowing affects not only what you eat and drink, but also the secretions that you make, the saliva that you naturally make all the time. We just swallow it without thinking about it. But when you have PSP, it's hard to do that. You have to really think about it. So it tends to accumulate in the mouth. And sometimes it could just drip down the throat and get down the wrong pipe, go down the windpipe, and tickle the vocal cords and cause coughing. So that's what the cause of it is. Usually the problem with liquids is worse than the problem with solid foods until much later in the course of PSP. What can be done to prevent it? Well, there's all sorts of therapies that are done by a speech and swallowing therapist. The first thing that I'll always do after I examine the patient myself is prescribe a formal swallowing evaluation in the hospital's speech and swallowing department, along with an X-ray procedure called a modified barium swallow. Modified barium swallow. A regular barium swallow is an X-ray movie of somebody drinking a fluid that has a dye in it, and the dye shows up on X-rays. And so it shows what the lining of the esophagus looks like as the person is swallowing the liquid. A modified barium swallow isn't for the esophagus, it's for the upper part of the swallowing mechanism, from the mouth through the back of the throat and down maybe to the larynx. And that will see how well the person manipulates a ball of solid food in their mouth, how well they chew it, how well they transfer it to the back of the mouth in preparation for swallowing, whether it gets stuck in various nooks and crannies in the back of the throat, whether it hangs up in various places. And depending on what they find, they will prescribe certain exercises or certain measures that can be taken, such as avoiding dry solid foods or chewing everything a certain number of times before trying to swallow, or following every swallow with a sip of water or some other liquid. It depends what they find on the exam and on the modified barium swallow. Or maybe just sitting up straight for a half an hour after every meal, or eating more frequent, smaller meals. There's just a long list of things that can be done for different types of problems. So that's the most important thing to do for swallowing problems in PSP. Very often people will, as I said, will have more problems with thin liquids at first than solids. And what can be done for that is to thicken up the thin liquids with, there are a number of commercial products that can do this. They're powders that you mix into the thin liquids to make them a little more gloppy. All right. Do you believe, here's an interesting question. Do you believe that autophagy will help with PSP? Okay, well, what is autophagy? Well, autophagy is not a treatment. It's a normal function of brain cells that takes care of, that disposes of worn out proteins or parts of cells, either worn out or defective from the time they were made, or maybe manufactured to excess, and the excess needs to be disposed of. And there's good reason to believe that there's a problem with autophagy in PSP, and that's what might allow the tau protein to persist in an abnormal form in the cell. There are many reasons why tau might be persisting, and that's just one of them. So really the question is, do I think that treatments that address the defects in autophagy might be helpful in PSP? And the answer is yes. This is a very, very active field. It's still at the level of the basic sciences. I don't know of any clinical treatments that are ready for human trials, but it's the autophagy problem really does seem to be a very important factor in the whole process of brain cells getting sick from PSP. So I think eventually that will result in some kind of useful prevention or way of slowing the progression of the disease. Okay, I think we're pacing pretty well. Light sensitivity. Recommendations for glasses. Someone recommended for my dad actually looking at getting some welding glasses. The reason that people are light sensitive if they have PSP is that there's irritation of the surface of the eyes because there's a reduced rate of blinking. The average blink rate for people with PSP is something like 5 blinks per minute, and normal it's about 25. So the eyes can really dry out, and the eyes will react by getting irritated, and the tear glands will react to the irritation by producing extra tears. That's why it's so common if you have PSP to have tears running down your cheeks. The problem is that it's not just these watery tears that are necessary to keep the eye lubricated. There's also an oil that's produced by glands in the eyelids, and that does not increase its secretion in response to drying and irritation. So there's still a need for the oil. So optometrists can treat this. Ophthalmologists can treat this different ways. There's a specialty called neurooptometry, where they specialize in things of neurological problems affecting the eyes. In other words, they don't just make glasses for refractive problems, for blurring. They make other types of things for if you have a problem with your eyelids, for example, of a neurological basis. But the place to start with the dry eyes is to keep them well lubricated with whatever lubricant you can get over the counter. The one that has hydroxymethylcellulose is a good place to start. But you should consult the ophthalmologist. There may be might be infection going on that can be treated. Maybe a steroid drop can cut down the inflammation. But if those things fail, then just wearing very dark glasses should be done. Okay, how much do PSP patients understand what's going on around them? Do we know? We're talking about people in the very advanced stages of PSP where they can't speak or write or show hand signs to indicate that they understand what's going on. They can still hear and they can still understand most of what's going on. That's because, and that's much more true for PSP than it is for Alzheimer's, because with Alzheimer's, the language ability of the brain is severely affected in most cases. And in PSP, it's not. There are other areas of the brain that are affected, but not language ability. Now, keep in mind, language ability is different from speech ability. So your ability to understand your language, somebody speaking, is not very much impaired in PSP, and the disease doesn't affect hearing at all. So yeah, the person who has advanced PSP and isn't moving much and not speaking, they can usually understand what's going on. They especially are able to understand the emotional content. So so an important part of caring for somebody with PSP is to be as emotionally encouraging as possible. It's very important. You know, in medical school, I remember the other students and I were all very, cynical about all this hand holding and things that we were taught that, but it's true. It really does work. The system of emotion in the brain is very important in the function of the rest of the brain and other organs as well. We have seen recent clinical study failures for anti-tau immunotherapies for PSP. That's these antibodies that are infused intravenously. There have been 2 trials of 2 different antibodies. The two antibodies are very, very similar, and they both failed to slow the progression of PSP. What do you view as the critical hurdle to developing an efficacious therapeutic for PSP? Is the development of robust biomarkers / diagnostics to identify the right patients the key barrier to finding an effective cure for PSP? Okay, well, this is a sophisticated question, and thank you to whoever submitted it. Just let me explain what it means. When you want to test a new drug, it's important to try to do 2 things. One is to, in choosing the patients to test it on, one is to make sure they've really got the disease that the treatment is designed for. And the other is to try to find them as early as possible in the course of the disease. Of course, you'd want your treatment to benefit people at every stage, but for the first trials, you would want people with as mild a case of the disease as possible, because they're the ones most likely to respond. And with PSP, that's not easy because we don't have a blood test. We don't have an imaging procedure that detects the disease at an early stage. And if we had those things, those are called biomarkers. If we had a good biomarker for the diagnosis of PSP, it would be a lot easier to test the drugs. But that's not the main hurdle. To answer the questioner's question, the main hurdle is finding a good drug. We don't know what might work or what might not work. There are so many different ways of approaching this because it's such a complicated process in the brain. There are so many different steps along the way that might be good drug targets that we don't yet have a a drug where we think that the only thing holding us back is the lack of a biomarker. What do you think about the scopolamine patch? It has helped my husband stop coughing at night, but now he has trouble walking and has stopped talking. Well, scopolamine is an old drug from back in the 1800s, which is an anticholinergic, is the class of the drug. There are many other anticholinergic drugs available, and they have the effect of drying out the secretions. It reduces the amount of saliva you make and the mucus that your throat and nose make. Also causes constipation. And the types of anticholinergics that can get through the blood-brain barrier and into the brain, they can cause all sorts of problems with, cause confusion or hallucinations. So now, and scopolamine does get into the brain. It's used as often as a seasickness, a travel sickness prevention, and it's available in a patch. So this person did improve in terms of coughing because it reduced the secretions, but it seems he's become weaker. It's hard to know what the weakness would be caused by. It may just be that the scopolamine has caused enough cognitive problem that it's made the person confused and unable to organize their motor activities. But another possibility is that these events are occurring over a long enough span of time that it's just the natural history of the disease that has progressed. Okay, let's keep going here. It's 1/4 to the hour. We're looking for alternative methods of communication for somebody whose speech is no longer recognizable. I mentioned before these high-tech devices that can detect blinks. Well, that's pretty high-tech. It's not widely available. It would require a huge amount of training. There are things that are much easier to institute. For example, just a normal low-tech pointing board with letters and commonly used words and phrases that could be just held up in front of the person, and they can point with a finger or with a pointer of some sort. Of course, it has to be held up high so that you don't ask them to look down at it, because it's tough to look down with PSP. And even if you can look down, it's hard to coordinate the gaze, hard to aim the gaze properly when you're looking down if you've got PSP. So there's that. There's electronic versions of that with a touch screen, a tablet. There's software that can be uploaded to a tablet or downloaded to a tablet where you just touch the letter or the word. Again, you have to be sure that the tablet is held or mounted at eye level for somebody with PSP. There's also speech enhancement devices, things that can just amplify the speech. These are things that neuro rehab doctors do all the time. This is routine for them. So I would strongly suggest consulting such a specialist. Okay, I think in the last 10 minutes, well, okay, here's one. This is very specific, but I'll turn it into a generic question. If somebody with PSP has what we call ventilatory arrhythmia, in other words, instead of just breathing in and out in a normal fashion, it becomes non-rhythmic, and there can be gasps, there can be all sorts of deep expirations, snoring type sounds. This doesn't happen so much in PSP. It happens a lot with multiple system atrophy. And the patient in question also was having attacks of sweating that looked like a seizure. Multiple system atrophy can do that. It causes instability of the autonomic system, and it can cause attacks of low blood pressure, which usually are accompanied by sweating, or it can just cause sweating without the low blood pressure. There can be a problem with temperature regulation with MSA. And of course, MSA and PSP can look a lot alike. It sometimes takes a pretty experienced neurologist to tell the difference between the two. So somebody who looks like they have PSP but has these autonomic nervous system problems like fluctuations in blood pressure and temperature and sweating, the diagnosis might actually be multiple system atrophy. But if you make that misdiagnosis, it's okay, because the treatment we have for both diseases is the same. You just treat the symptoms as they appear. And regardless of which disease the symptom is part of, it's still treated the same. Okay, I think we can go to the Q&A.
Thank you, Dr. Golbe. We've been receiving a lot of questions, and to all that have posed a question in the Q&A, thank you for participating. So let's see here. One question is, can PSP be confirmed without an MRI?
The answer is yes. I mean, I can do it. From doctors who aren't as experienced in recognizing PSP, it's good to rule out other things. Sometimes multiple little strokes can look like PSP. I mean, I'll get an MRI in everybody with PSP, but sometimes I don't really need it, but still I'll get it just to be sure. Multiple little strokes. There's a condition called normal pressure hydrocephalus, which is very easily recognized on MRI and is treated very different from PSP. But still, it doesn't really look like PSP to somebody who really knows PSP, but still, it's worth looking for. You may have heard about the hummingbird sign of PSP. That doesn't start happening until later in the course of the disease, till the mid, till maybe the 3rd or 4th or 5th year. And it's not really necessary to make the diagnosis at all. And what was the second part of the question?
That was the only question, the only part. So thank you.
Okay, good.
Another question we have is, what about dry mouth, but also at the same time having excess saliva and excess nasal secretions? Fits of coughing, and spitting out excess saliva at the same time. Is the fear that there might be, that she may aspirate some sort of fluid into the lungs a common fear in PSP?
Well, it's certainly a common fear, and with good justification. Even just a little bit of fluid going down into the lungs on a frequent basis can set up pneumonia. And so because the fluid, the saliva or the beverage can irritate the lungs and may have bacteria along with it, but even if it just irritates the lung tissue without actually having bacteria, still irritated lung tissue, it's inflamed, and it's more likely to get infected subsequently just from bacteria that's floating around in the air. So if you have a dry mouth and excessive secretions, I assume what they mean by that is a dry mouth and excessive nasal or throat secretions. That might be treatable by sucking on a lollipop. I know I sound like a real country doc here, but when you suck on a lollipop, it stimulates the saliva, but it also stimulates the swallowing reflex. And so that may solve both problems at the same time. Plus, it's fun.
Great. In our last few minutes, I think it would be helpful to talk a little bit about COVID-19. There have been a couple of questions that have come in about visiting patients who have PSP amidst the COVID-19 crisis, especially with the fact that we're seeing a lot of states that are seeing a rise in cases right now. I think it would be helpful to talk a little bit about precautions to take with PSP and related diseases and COVID-19.
Well, all of the diseases we're talking about, not just PSP, but MSA, CBD, are, they affect the ability to produce, to expectorate secretions. That's an important part of recovery from pneumonia. Now, the pneumonia of COVID isn't usually one that produces a lot of secretions, but sometimes it does. And you have to be able to cough those up. And if you can't, then the nurses in the hospital will suction, will insert a flexible plastic tube down into the throat and activate a vacuum apparatus that sucks out the secretions. But that doesn't work as well, of course, as a natural cough. And so if you have a deficit in coughing, then, and you do get the COVID infection, then you're at a higher risk of dying from it. So people with PSP and these other diseases have to be classified in the high risk category, even aside from the fact of their age. So there's two reasons. And when everybody else is going out to the, meeting in somebody's backyard and, oh yeah, there'll be distancing and, oh yeah, we'll wear masks when we're not eating, stay home.
Thank you. I have a question here. Is it common for someone with PSP to have memory or cognitive issues showing up intermittently for several years before any balance issues show up?
Yes, that can definitely happen. PSP will start, the first symptom of PSP will be something related to cognition or behavior in about a third of all patients who eventually develop full-blown PSP. And usually this is something more behavioral than cognitive. In other words, it'll be a change in personality. The person will be less interested in social interactions, that kind of thing. Or they may start to look anxious, or they may just be uninterested in things in general, called apathy. But sometimes it's more cognitive. It's more of a memory problem, more of a word finding problem. But that's more unusual. But yes, it can definitely happen. It's more common in Alzheimer's disease, of course. But also you have to realize that just having a hard time finding words is common in the normal healthy population once they get into their 50s and 60s.
Great. Well, I think that is all of the time that we have for more questions. So I just want to say thank you, Dr. Golbe, for taking the time to answer all these questions. We really appreciate your time and your commitment to this webinar series.
Glad to do it, and let's keep doing it.
Absolutely. So at this time, thank you everyone for submitting so many wonderful questions for today's webinar. It's with your involvement and your donations that we are able to continue this webinar series. This is Ask the Doctor number 4 today. Please mark your calendars for Ask the Doctor number 5, which is going to feature Dr. Alexander Panteliat on Tuesday, August 11th at 2 p.m. Eastern Time. A link to register for that will be sent in a follow-up email. Like all of our previous Ask the Doctor webinars, this video, the recording of this video will be archived on our CurePSP TV YouTube channel and also on our website, which is www.curepsp.org. Right from our homepage, you can access our coronavirus resources page, which is where all of the previous recordings from the Ask the Doctor webinars are archived. A lot of questions that have been asked today and sent in previous to today have already been answered in the previous webinars. So please take a moment to visit those webinars, take a piece of paper with you and a pen so that you can take some notes. There's a lot of really, really valuable information shared from Dr. Golbe in those previous webinars. In addition to that, the CurePSP team is currently organizing all of the information that has been shared by Dr. Golbe in the previous webinars. So all of the information will be made available shortly on our website. So please stay tuned for that. And again, we'll see you again on August 11th at 2 p.m. with Dr. Alexander Panteliat. And thank you all so much for your donations and for your participation today. And again, thanks to Dr. Golbe, to CurePSP for providing this platform, and to Jacqueline Zendrian. Thank you all so much, and have a good evening.